Acute pancreatitis, a question and answer podcast. Welcome to our podcast episode where we delve into the essentials of acute pancreatitis management for general surgery residents. In this episode, we present 100 commonly asked questions and answers, ensuring clarity and depth for listeners at every stage of their medical training. Pause the video after each question to attempt answer. Let's begin. Definition, pathophysiology, and diagnosis. Question: what is the definition of acute pancreatitis? Answer: acute pancreatitis is an acute inflammatory process of the pancreas, with variable involvement of other regional tissues or remote organ systems. Question: what are the two most common causes of acute pancreatitis? Answer: the most common causes are gallstones, accounting for 40 to 70% of cases, and chronic ethanol abuse, accounting for 25 to 35%. Together, they are responsible for 80% of cases. Question: what are other common causes of acute pancreatitis? Answer: other causes include elevated triglyceride levels greater than 1000 mg per deciliter, elevated calcium levels, endoscopic retrograde cholangiopancreatography procedures, trauma, medications, pancreatic duct obstruction, viral infections, and autoimmune conditions. Question: what are the pathophysiological steps in acute pancreatitis? Answer: the inappropriate activation of pancreatic enzymes such as trypsin within the pancreas leads to autodigestion, inflammation, vascular injury, and necrosis. Question: what are the two key diagnostic criteria for acute pancreatitis? Answer: a patient must meet at least two of the following three criteria: abdominal pain consistent with acute pancreatitis, serum amylase or lipase greater than 3 times the upper limit of normal, and characteristic findings on cross-sectional imaging such as computed tomography or magnetic resonance imaging. Question: why is lipase more specific than amylase for pancreatitis? Answer: lipase rises earlier and remains elevated longer, up to 14 days, whereas amylase can be elevated in many other conditions, including macroamylasemia, salivary gland disorders, bowel obstruction, and ischemia. Question: a patient has classic pain and a lipase of 2.5 times the upper limit of normal. Is this acute pancreatitis? Answer: not according to the Atlanta criteria. The patient must meet a third feature, such as confirmatory imaging, to formally diagnose acute pancreatitis. Question: what is the most important initial imaging study for acute pancreatitis? Answer: transabdominal ultrasound is the initial imaging study of choice. It is primarily used to assess for gallstones and biliary ductal dilation, rather than to diagnose pancreatitis itself. Question: when is a computed tomography scan indicated in the initial phase? Answer: a computed tomography scan is not routinely indicated. It is used when the diagnosis is uncertain, to rule out other catastrophic causes of abdominal pain, or if there is clinical deterioration despite 48 to 72 hours of medical management. Question: what is the role of magnetic resonance imaging or magnetic resonance cholangiopancreatography? Answer: magnetic resonance imaging and magnetic resonance cholangiopancreatography are excellent for detecting cholelithiasis, defining pancreatic duct anatomy, and characterizing fluid collections. They are superior to computed tomography for detecting non-calcified stones and duct disruption. Initial assessment, scoring, and prognostication. Question: what are the two phases of acute pancreatitis? Answer: the early phase, which is the first week, is characterized by a systemic inflammatory response syndrome and organ failure. The late phase, beyond the first week, is characterized by local complications such as necrosis and fluid collections. Question: what is the most important prognostic factor in the first week? Answer: the development of persistent organ failure lasting greater than 48 hours is the most important prognostic factor and is the primary driver of mortality. Question: what are the three organ systems used to define organ failure in pancreatitis? Answer: the respiratory system, with a partial pressure of oxygen to fraction of inspired oxygen ratio less than 300. The cardiovascular system, indicated by hypotension requiring pressors, and the renal system, with creatinine greater than 1.7 mg per deciliter or urine output less than 0.5 ml per kilogram per hour. Question: what is the purpose of scoring systems such as Ranson's criteria? Answer: scoring systems like Ranson's criteria are used to predict severity and mortality in acute pancreatitis and to help identify patients who may need intensive care unit level care. Question. What are the components of Ranson's criteria on admission? Answer. The components are age greater than 55 years, white blood cell count greater than 16,000, glucose greater than 200 mg per deciliter, lactate dehydrogenase greater than 350, and aspartate aminotransferase greater than 250. Question. What are the components of Ranson's criteria at 48 hours? Answer. The criteria are hematocrit drop greater than 10%, blood urea nitrogen rise greater than 5, calcium less than 8, base deficit greater than 4, and fluid sequestration greater than 6 liters. Question. What is the modified Glasgow score? Answer. The modified Glasgow score, also called the Emery score, includes 8 factors: age, white blood cell count, glucose, lactate dehydrogenase, aspartate aminotransferase, albumin, calcium, and partial pressure of oxygen. A score of 3 or greater predicts severe disease. Question. What is the bedside index for severity in acute pancreatitis score? Answer. The bedside index for severity in acute pancreatitis is a simple 5-factor score assessed within 24 hours. Blood urea nitrogen greater than 25, impaired mental status, systemic inflammatory response syndrome, age greater than 60, and pleural effusion. A score of 3 or higher predicts increased mortality. Question. What is the most widely used contemporary scoring system for acute pancreatitis? Answer. The Acute Physiology and Chronic Health Evaluation 2 score is the most widely used contemporary system. It is accurate but complex, and a score of 8 or greater predicts severe disease. Question. What is the role of systemic inflammatory response syndrome criteria? Answer. The presence of 2 or more systemic inflammatory response syndrome criteria on admission is a simple and early predictor of severe pancreatitis. Question. What is the most accurate predictor of severity in acute pancreatitis? Answer. Persistent organ failure is the most accurate predictor of severity. Scoring systems are guides, but the patient's clinical course is paramount. Question. What laboratory value serves as a marker of pancreatic necrosis? Answer. An elevated C-reactive protein greater than 150 mg per liter at 48 hours is a good predictor of necrotizing pancreatitis. Question. What is the significance of hemoconcentration in acute pancreatitis? Answer. An admission hematocrit greater than 44% or failure of hematocrit to decrease with fluid resuscitation is associated with pancreatic necrosis and organ failure. Initial medical management. The first 48 to 72 hours. Question. What is the single most important intervention in early acute pancreatitis management? Answer. Aggressive, goal-directed intravenous fluid resuscitation is the most important early intervention. Question. What type of fluid should be used for resuscitation? Answer. Isotonic crystalloid fluid is recommended. Lactated Ringer's solution is preferred over normal saline due to its more physiologic pH and reduced risk of hyperchloremic metabolic acidosis. Question. What are the initial fluid goals in acute pancreatitis management? Answer. The initial fluid goals are a bolus of 15 to 20 milliliters per kilogram, followed by 250 to 500 milliliters per hour. The goals are to restore urine output greater than 0.5 milliliters per kilogram per hour and normalize heart rate and blood pressure. Question. What is the danger of under-resuscitation in acute pancreatitis? Answer. Under-resuscitation can lead to pancreatic hypoperfusion, resulting in necrosis and organ failure. Question. What is the danger of over-resuscitation in acute pancreatitis? Answer. Over-resuscitation can lead to abdominal compartment syndrome, pulmonary edema, and worsening third spacing. Question. How should fluid resuscitation be monitored? Answer. Monitor vital signs, urine output, and serial clinical examinations. In complex cases, central venous pressure monitoring or pulse contour analysis may be considered. Question. What is the role of early enteral nutrition in acute pancreatitis? Answer. Early enteral nutrition via nasogastric or nasojejunal tube preserves gut mucosal integrity, prevents bacterial translocation, and reduces infection rates. It is preferred over total parenteral nutrition. Question. When should enteral nutrition be started in acute pancreatitis? Answer. Enteral nutrition should be started within 24 to 48 hours of admission, once volume resuscitation is complete and the patient is hemodynamically stable. Question. What is the preferred route for enteral feeding in acute pancreatitis? Answer. The nasojejunal tube is preferred, as it delivers nutrients beyond the ligament of Treitz. However, nasogastric feeding has been shown to be equally effective and is often easier. Question: what is the role of prophylactic antibiotics in acute pancreatitis? Answer: prophylactic antibiotics are not recommended. Antibiotics should only be given for a specific, proven concurrent infection such as cholangitis, urinary tract infection, or infected pancreatic necrosis. Question: what is the role of pain control in acute pancreatitis? Answer: patient-controlled analgesia with opioids is the mainstay of pain management. Nonsteroidal anti-inflammatory drugs can be used adjunctively. Morphine is avoided because it may cause sphincter of spasm. Hydromorphone or fentanyl are preferred. Question: why should meperidine be avoided in acute pancreatitis? Answer: meperidine is avoided because its neurotoxic metabolite, normeperidine, can cause seizures. It is no longer recommended. Management of complications and the late phase. Question: what are the local complications of acute pancreatitis? Answer: local complications include acute peripancreatic fluid collection, pancreatic pseudocyst, acute necrotic collection, and walled-off necrosis. Question: what is the difference between an acute peripancreatic fluid collection and a pseudocyst? Answer: an acute peripancreatic fluid collection occurs in interstitial edematous pancreatitis, lacks a defined wall, and occurs in less than 4 weeks. A pseudocyst is a mature, encapsulated collection of pancreatic fluid with a defined wall that persists for more than 4 weeks, and it contains no solid debris. Question: what is the difference between an acute necrotic collection and walled-off necrosis? Answer: an acute necrotic collection contains both fluid and necrotic material, has no defined wall, and occurs in less than 4 weeks. Walled-off necrosis is a mature, encapsulated collection of necrotic material with a defined wall that persists for more than 4 weeks. Question: what is the most feared complication of necrotizing pancreatitis? Answer: infected pancreatic necrosis is the most feared complication, occurring when bacteria translocate into necrotic tissue, dramatically increasing mortality. Question: how is infected necrosis suspected? Answer: infected necrosis is suspected in cases of clinical deterioration after initial improvement, new onset fever, leukocytosis, or rising inflammatory markers. Question: how is infected necrosis diagnosed? Answer: it is diagnosed by computed tomography-guided fine needle aspiration of the collection for gram stain and culture. In the appropriate clinical context, gas bubbles within the necrosis on computed tomography are pathognomonic for infection. Question: what is the step-up approach for managing infected necrosis? Answer: the approach involves antibiotics if the patient is stable, image-guided percutaneous drainage to control sepsis, minimally invasive necrosectomy if needed, and open surgery as a last resort. Question: what antibiotics penetrate pancreatic necrosis? Answer: carbapenems such as imipenem, quinolones such as ciprofloxacin with metronidazole, and high-dose ceftazidime are effective. Question: when is endoscopic retrograde cholangiopancreatography indicated in acute pancreatitis? Answer: endoscopic retrograde cholangiopancreatography is indicated for acute gallstone pancreatitis with concomitant cholangitis or persistent biliary obstruction, such as jaundice or dilated common bile duct on ultrasound. Routine endoscopic retrograde cholangiopancreatography is not beneficial. Question: what is abdominal compartment syndrome and how is it managed? Answer: abdominal compartment syndrome is sustained intra-abdominal pressure greater than 20 mm of mercury with new organ failure. It is managed with nasogastric or rectal decompression, sedation, avoiding over-resuscitation, and ultimately, percutaneous drainage or decompressive laparotomy. Question: when should a cholecystectomy be performed for gallstone pancreatitis? Answer: cholecystectomy should be performed during the same admission once the pancreatitis has subsided, indicated by pain resolution, trending down amylase and lipase levels, and the patient tolerating diet. Question: what if the patient is too ill for surgery during the same admission? Answer: in such cases, interval cholecystectomy should be performed 4 to 6 weeks later. If surgery is not possible, endoscopic sphincterotomy can be considered as a temporizing measure. Question: what is the management for sterile pancreatic necrosis? Answer: asymptomatic sterile necrosis does not require intervention regardless of size. Management is conservative with supportive care. Question: what is the management for asymptomatic pseudocyst? Answer: management involves drainage, with options including endoscopic cyst gastrostomy, percutaneous drainage, or surgical cyst gastrostomy. Question: what is the management for symptomatic or infected walled-off necrosis? Answer: drainage and necrosectomy are required, with the preferred first-line approach being endoscopic transluminal drainage and necrosectomy. Surgical management and miscellaneous question: what is the role of open surgical necrosectomy? Answer: open surgical necrosectomy is now a last resort due to high morbidity and mortality, reserved for failures of the step-up approach or patients with catastrophic complications such as uncontrolled bleeding. Question: what is video-assisted retroperitoneal debridement? Answer: video-assisted retroperitoneal debridement is a minimally invasive technique where a tract is created into the retroperitoneum via a small flank incision, allowing a scope to be used for debriding necrotic material. Question: what is the most common cause of death in the first week of acute pancreatitis? Answer: overwhelming systemic inflammatory response syndrome leading to multiple organ system failure is the most common cause of death in the first week. Question: what is the most common cause of death after the first week? Answer: infected pancreatic necrosis and its sequelae, such as sepsis and hemorrhage, are the most common causes of death after the first week. Question: what is walled-off necrosis? Answer: walled-off necrosis is the final stage of an acute necrotic collection, where the collection becomes encapsulated by a well-defined inflammatory wall, usually after 4 weeks. Question: what is the significance of splenic vein thrombosis? Answer: splenic vein thrombosis can result from local inflammation, leading to left-sided portal hypertension, gastric varices, and gastrointestinal bleeding. Question: what is the management of a pancreatic fistula? Answer: most pancreatic fistulas close with conservative management, including nothing by mouth, total parenteral nutrition or distal enteral feeding, and octreotide. Endoscopic retrograde cholangiopancreatography with stent placement may be needed for duct disruptions. Question: what is the most common source of hemorrhage in severe pancreatitis? Answer: erosion of a major peripancreatic vessel, such as the splenic artery or gastroduodenal artery by pancreatic enzymes, resulting in pseudoaneurysm formation is the most common source. Question: how is a bleeding pseudoaneurysm diagnosed and treated? Answer: it is diagnosed by contrast-enhanced computed tomography showing active extravasation and treated with angiography and embolization by interventional radiology. Question: what is the role of surgery for bleeding? Answer: surgery is considered only if embolization fails or is unavailable and the patient is exsanguinating. Question: how is hypertriglyceridemia-induced pancreatitis treated? Answer: treatment includes standard supportive care, insulin drip even in non-diabetics to stimulate lipoprotein lipase, and therapeutic plasma exchange for severe cases to rapidly lower triglyceride levels. Question: when should autoimmune pancreatitis be suspected? Answer: suspect autoimmune pancreatitis in a patient with painless jaundice, a sausage-shaped pancreas on imaging, and elevated immunoglobulin G4 levels. This condition responds to steroids, not surgery. Question: what is groove pancreatitis? Answer: groove pancreatitis is a rare form of chronic pancreatitis that affects the area between the pancreatic head, duodenum, and common bile duct. It can mimic pancreatic cancer. Question: what is the role of routine daily laboratory tests in acute pancreatitis? Answer: daily laboratory tests monitor complete blood count, comprehensive metabolic panel, calcium, magnesium, and phosphorus, looking for trends indicating resolution or complications such as rising blood urea nitrogen or creatinine for renal failure and falling hematocrit for hemorrhage. Question: what is the role of computed tomography with intravenous contrast in the late phase? Answer: it is used to diagnose and characterize local complications, including necrosis, fluid collections, and vascular complications. Computed tomography should be performed at least 72 to 96 hours after onset for necrosis to become radiologically apparent. Question: why should early contrast-enhanced computed tomography be avoided? Answer: early computed tomography may be normal. Necrosis is not radiographically evident for 48 to 72 hours, as it takes time for perfusion defects to become demarcated. Question: what is the colon cutoff sign on X-ray? Answer: the colon cutoff sign is a distended transverse colon with a paucity of gas in the descending colon, due to colonic spasm adjacent to the inflamed pancreas. It is a nonspecific sign. Question: what is the sentinel loop sign on X-ray? Answer. The sentinel loop sign is a focally dilated loop of small bowel, often in the left upper quadrant, due to localized ileus from pancreatic inflammation. Question. What is the role of urinary trypsinogen 2? Answer. Urinary trypsinogen 2 is a rapid dipstick test with high specificity, used in some emergency departments as an adjunct for diagnosis but not a standard replacement for serum lipase. Question. What is the role of early mobilization in acute pancreatitis? Answer. Early mobilization is important to prevent intensive care unit acquired weakness and other complications of immobility once the patient is hemodynamically stable. Rapid fire clinical pearls. Question 71 to 100. Question. What is the most common organism causing infected necrosis? Answer. Escherichia coli, followed by Klebsiella, Enterococcus, and Staphylococcus species are the most common organisms. Question. What is the mortality rate for interstitial edematous pancreatitis? Answer. The mortality rate is less than 1%. Question. What is the mortality rate for sterile necrotizing pancreatitis? Answer. The mortality rate is approximately 10%. Question. What is the mortality rate for infected necrotizing pancreatitis? Answer. The mortality rate is approximately 25 to 30%. Question. True or false? The extent of pancreatic necrosis correlates directly with the risk of organ failure. Answer. True. More extensive necrosis, greater than 30%, is associated with a higher risk. Question. What is the most common cause of death in the late phase of acute pancreatitis? Answer. Sepsis from infected necrosis is the most common cause. Question. What is the most common electrolyte abnormality in acute pancreatitis? Answer. Hypocalcemia, due to saponification of peripancreatic fat, is the most common abnormality. Question. What is Gray-Turner's sign? Answer. Gray-Turner's sign is bluish discoloration of the flanks, caused by retroperitoneal blood dissecting through tissue planes. Question. What is Cullen's sign? Answer. Cullen's sign is bluish discoloration around the umbilicus, with the same etiology as Gray-Turner's sign. Question. Are Gray-Turner and Cullen's signs common in acute pancreatitis? Answer. No, they are rare but specific signs of severe hemorrhagic pancreatitis. Question. What is the role of octreotide in acute pancreatitis? Answer. Octreotide is a somatostatin analog that reduces pancreatic exocrine secretion. Its benefit in acute pancreatitis is unproven and it is primarily used for treating pancreatic fistulas. Question. What is the role of probiotics in acute pancreatitis? Answer. Probiotics are not recommended, as studies have shown no benefit and a potential for increased complications. Question. What is the role of lixipophant in acute pancreatitis? Answer. Lixipophant is an experimental platelet activating factor antagonist that showed no mortality benefit in clinical trials and is not used. Question. What is the role of enteral glutamine in acute pancreatitis? Answer. Enteral glutamine may be beneficial as a supplement in total parenteral nutrition to reduce infectious complications, but current evidence is not strong enough for routine use. Question. When is a feeding jejunostomy tube indicated in acute pancreatitis? Answer. A feeding jejunostomy tube is indicated for patients with a prolonged course and inability to tolerate oral intake who require long-term enteral access. Question. What is the differential diagnosis for a pancreatic fluid collection? Answer. The differential diagnosis includes cystic pancreatic neoplasm, macrocystic serous cystadenoma, and mucinous cystic neoplasm. Question. What is the most common extrapancreatic site of infection in acute pancreatitis? Answer. Pneumonia is the most common extrapancreatic infection. Question. What is the role of low molecular weight heparin in acute pancreatitis? Answer. Low molecular weight heparin is important for deep vein thrombosis prophylaxis in immobilized, hypercoagulable patients. Question. What is the most common type of pancreatic fistula? Answer. The most common type is an external pancreatic fistula, usually originating from percutaneous drainage catheters. Question. What is the management of a disconnected duct syndrome in acute pancreatitis? Answer. Disconnected duct syndrome results from severe necrosis causing disruption of the main pancreatic duct and is managed with long-term transmural drainage, either endoscopic or surgical, or distal pancreatectomy. Question. What is the role of endoscopic retrograde cholangiopancreatography in pancreatic duct leaks? Answer. Endoscopic retrograde cholangiopancreatography can be used to place a pancreatic duct stent to bridge the disruption and promote healing. Question. When should a vascular complication be suspected in acute pancreatitis? Answer. Suspect a vascular complication with a sudden drop in hematocrit, new pulsatile mass, or sudden hemodynamic collapse. Question. What is the most common cause of recurrent acute pancreatitis? Answer. Gallstones are the most common cause, followed by alcohol. If both are ruled out, structural or metabolic causes should be considered. Question. What is pancreativism? Answer. Pancreativism is a common congenital variant in which the dorsal and ventral pancreatic ducts fail to fuse. It is a controversial cause of recurrent pancreatitis. Question. What is the role of sphincter of Oddi manometry in pancreatitis? Answer. Sphincter of Oddi manometry is used to diagnose sphincter of Oddi dysfunction, a cause of recurrent idiopathic pancreatitis. Question. What is the role of genetic testing in acute pancreatitis? Answer. Genetic testing is used to detect mutations such as cystic fibrosis transmembrane conductance regulator, serine protease inhibitor Casl type 1, and cationic trypsinogen gene in patients with idiopathic recurrent acute pancreatitis or a strong family history. Question. What is the most common indication for surgery in chronic pancreatitis? Answer. Intractable pain is the most common indication. Question. What is the Fry procedure? Answer. The Fry procedure is a surgical technique for chronic pancreatitis involving longitudinal opening of the pancreatic duct and local excision of the pancreatic head, combining drainage and resection. Question. What is the most important principle in managing severe acute pancreatitis? Answer. The most important principle is supportive care and prevention of complications. There is no single solution. Meticulous management of fluids, nutrition, and organ systems is essential. Question. What is the final take-home message for residents regarding acute pancreatitis management? Answer. Management should be thought of in phases. Resuscitate, feed, identify complications, and intervene only when necessary. Avoid early computed tomography and never give prophylactic antibiotics. Thank you for joining us for this podcast episode on acute pancreatitis. This comprehensive question and answer format is designed to empower residents with the knowledge and confidence needed to provide optimal patient care. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.